Good morning, everyone. I'm delighted to see all of you here for this important event for those of us in development, because we want to talk today about Ebola after Ebola, what to do about development after Ebola. I'm Nancy Birdsall, the president of the Center for Global Development, and I have the great pleasure of starting off this morning's discussion by introducing Senator Jeff Flake of Arizona, who will be talking to us for about 10 or 15 minutes and then has agreed to answer some questions. Senator Flake has been in the Congress for 14 years. In all that time, he's been a strong voice for U.S. Africa policy, pushing for economic growth promotion and for increased trade with the continent. You know, a lot of us have been talking in the last few years about rising Africa. Senator Flake was ahead of his time in that respect. His interest in the African continent dates back well before his election to the Congress and now more recently to the Senate. He served as a Mormon missionary in Southern Africa and returned a few years later to monitor Namibia's transition to independence as executive director of the Foundation for Democracy in Namibia. So he's a democracy wonk and a trade wonk and an economic growth wonk, perfect for the Center for Global Development. We're having trouble in Washington. We talk a lot about how polarized the climate has become. Senator Flake is known for his bipartisanship, for reaching across the aisle to tackle big challenges. He's been the ranking member of the Senate Subcommittee on Africa, the Senate Foreign Relations Subcommittee on African Affairs, and we look forward to the moment we hope that he will become chairman of this important subcommittee. It's a very important subcommittee for anyone concerned with development issues in the world. In that role, he's poised to play a central role in shaping U.S. policy toward Liberia, toward West Africa, the three countries that have suffered most from the Ebola epidemic, and to the continent as a whole. So we're very grateful. It's tough for people like Senator Flake to make it downtown, particularly during rush hour. We're really grateful to have you here, Senator Flake. Let me give you the floor, and let us give him a big welcome.
Well, I appreciate the opportunity to be here. It is nice to get away from Capitol Hill, if only for a few minutes. But as mentioned, I have a long-term love affair with Africa. It started a long time ago when I was just a kid. I remember we had a consultant on our ranch. I grew up on a ranch in northern Arizona. I have 10 brothers and sisters. I have 69 first cousins on my father's side alone. I grew up in the town of Snowflake, named after my great-great-grandfather, William Jordan Flake, and then a family named Snow, and serious. So when they say, everybody thinks it's because it does snow there. It does snow in Arizona some places, but it is a combination of the two Flake names. But people say that Congress's popularity is down to paid staff and blood relatives. I plan to ride that blood relative popularity for a long, long time if I can, with a big family there. In fact, growing up in Snowflake with the name of Flake, I never knew that Flake was a pejorative term until I left town. And when I came here to actually do an internship in 1987 for Dennis DeConcini, a Democrat. I've had to purge that from my record ever since as a Republican. But during that time, I went to a reception, and it came up in conversation with that I had with somebody that my name was, or I'm sorry, that I had come from Snowflake. The person I was talking to knew that I came from Snowflake, but he didn't know my name was Flake. And it turned out he knew somebody from Snowflake. He couldn't recall the name. He struggled for a long time, and I thought I'd narrow it down. I said, "Was this guy a Flake?" And it was an innocent question at the time. He said, No, he seemed pretty normal to me. So that was my introduction to it was going to be a long life. So I figured after all, if there's one other place where there are a lot of flakes, and that's in Congress. And so it turned out to be a good transition when it happened. But as a kid growing up on the ranch, we had a ranch consultant from Rhodesia back in the 70s. He had actually been exiled. He was a Liberal member of Parliament there, but he was also a game warden, and he told stories of flying his plane so low that the giraffes would look down on him. And it just was fascinating to me as a kid growing up on a dry, dusty ranch in Arizona. And I always dreamed of going to Africa. I then was called to serve there as a missionary in the country of South Africa, and then also Zimbabwe as well. And that just whetted the appetite. 7 years later, returned, as mentioned, to the country of Namibia, and was there when Namibia received its independence. Long awaited, and I was there for that year, April 89 to April 90. And for a political junkie, there's no better fix than that, to be in a country when it has its first elections and writes its constitution. It was just a wonderful experience. Ever since that time, African affairs have captivated my interest, and it's been particularly gratifying to see so many African countries, like Liberia, make great strides toward freedom after years of terrible and prolonged strife. And those strides benefit not just the countries that are involved, but also the economy and the security situation of surrounding countries, and really all nations around the world. I think everybody here agrees, that I know that everyone here agrees, that we can't allow a deadly epidemic like Ebola to lay waste to the progress that a country like Liberia has made, nor can we allow it to prevent Liberia from building on the hard-fought progress that it has made. Now, and as we work to bring this outbreak under control, our collective challenge has to be to ensure that this never happens again. The global nature of the Ebola threat at first led many to presume that the World Health Organization would stop the outbreak dead in its tracks, that it could do so on its own. But to describe the response of the WHO to this disaster as lacking would be very charitable. Director General Margaret Chan said, quote, "Like the rest of the world, WHO was slow to respond to the outbreak. But WHO is not the rest of the world." That's like me saying, like the rest of the country, the Senate failed to pass legislation this year. That's our charge. That's our duty. That's what we should do. That's an excuse that WHO cannot or should not get away with. Some have suggested that a reformed World Health Organization with a more robust budget would be our strongest line of defense, and the defense against future outbreaks of diseases like Ebola. To be sure, WHO is in dire need of reform. While the first cases of the highly contagious disease were reported in December of 2013, it wasn't until August of 2014, and after the deaths of more than 1,000 Africans, that the organization declared the Ebola outbreak to be a global emergency. Think of that, not until August. WHO leadership knows that it's under fire. Later this month, it'll convene a special session of the Executive Board to examine the response to the Ebola outbreak and consider steps to avoid a repeat occurrence. I commend the WHO for recognizing its weak performance, and I believe additional scrutiny is certainly warranted. However, if past is prologue, I'm not confident that reforms will have any positive effects on future epidemics. After all, regulations in place in 2005 required WHO members to report outbreaks of dangerous diseases, and that, as we know, didn't seem to work this time around. I believe the WHO would have better luck if it were to stop concerning itself with the overconsumption of energy drinks or the rate of global tobacco taxes, and stick with a mission more focused on prevention of infectious disease outbreaks. And while the WHO charts a path forward with internal reforms, it's imperative that the United States continue to demonstrate leadership. Leadership not just in helping Liberia stop the Ebola outbreak, but in helping identify solutions to prevent future ones as well. Let me repeat. The response of the United States to the Ebola outbreak demonstrated once again that no international organization is a substitute for American leadership. Now, there's been a lot of talk of strengthening Liberia's health system. Before the outbreak, health systems in Liberia had, in fact, improved from their post-war state. Minister Moore and I spoke about that yesterday in my office. However, they were clearly not up to the task of defeating a deadly infectious disease that had never before been seen on the streets of Monrovia. We had a hearing on the Ebola response in the Senate Foreign Relations Committee, African Affairs Subcommittee in December, and we heard testimony cataloging the various needs of Liberia's health system as it continues to battle the disease. Not surprisingly, every witness made clear that a first-rate health system is necessary to make sure that an outbreak of this scale never happens again. And while it is essential for the United States and partner countries to provide Liberians with what they need right now to address the epidemic, that model is not economically sustainable. Nor will this model support the kinds of preventive solutions that will head off similar scenarios in the future. We need something different. Simply put, the kind of health system necessary to address outbreaks while managing other problems can only be sustained by the Liberians themselves. And beyond short-term donations from willing nations to handle the present crisis and coordination from countries like the United States and organizations at the UN, the only way to achieve this is to make sure that economic progress continues in Liberia in the face and in the wake of this deadly disease. Helping facilitate sustained economic progress in Liberia should be one of the primary focuses of the United States government as it looks to address and prevent future outbreaks of this nature. There is no substitute for sustained economic growth. As the cost of doing business in Liberia skyrockets and as the effects of these costs begin to cascade, the public sector needs to do its part to create an environment where the private sector not only survives, but thrives. This will not be easy. Liberia and other countries in the region have been experiencing economic growth in excess of 5% a year. Such growth has fallen victim to Ebola. The World Bank expressed concern a while ago that Ebola might wipe out years of economic growth in the affected countries because of border closures and decreased regional and domestic trade and production and job losses. And let me just say, as bad as it is in terms of economic growth in the economy, it could have been worse had some countries followed the advice of some to shut down air travel completely. And I want to commend the Obama administration for resisting those calls from many quarters. And I want to thank those in this room and elsewhere who consistently ask for another path, realizing that we could manage this without going to those measures. Can you imagine trying to rebuild those economies when you're still trying to get out of complete air travel bans and the like? And so that's one thing that I'm glad we didn't go further on. At a minimum, foreign assistance from donor governments like the United States needs to be targeted to returning Liberia to a period of sustained economic growth. Minister Moore and I spoke about some of these measures in my office yesterday. We need to ensure with whatever aid that we provide that we involve private sector partners, those who can continue and sustain this activity after these projects are completed. And we want to make sure, and I will make sure, that our aid is geared in that way. We also need to ensure that a lot of the funding that has been programmed, where we have made progress more quickly than we thought, that we act nimbly to reprogram those funds if need be to areas that are more dire. And as I mentioned, there is no more important task than rebuilding the private sector, making sure the private sector can move forward in Liberia. I've often been critical of the way some of our foreign assistance is obligated, but used in the right way, particularly when oriented towards supporting long-term goals of economic progress. Foreign aid is one of the most important tools that we have to affect positive change outside of our own borders. Now, among the benefits, investing in the viability of the Liberian economy will create conditions that can lead to a top-notch health infrastructure capable of managing infectious diseases before they become outbreaks. Again, when you have a thriving economy, when you have a growing economy, you can do the other things that you need to, including standing up sustainable health facilities and infrastructures that can deal with future outbreaks. We will also need to facilitate trade and investment in this area of the world that has so much to offer. And as the incoming chairman of the Subcommittee on African Affairs, I look forward to taking up this challenge in the months ahead. We're fortunate. The Africa Affairs Subcommittee has always been a bipartisan effort. Senator Chris Coons has been chairing the committee. He traveled to the region just last month. Chris and I have a good working relationship, and I look forward to working with Chris, and I will rely on his expertise and advice as we move forward, and we will work together. But I look forward to this challenge in the months ahead. I look forward to hearing the results of this conference. I wish I could stay and listen to more of what's going on here today, but I really anticipate getting to work on what's going on in West Africa, and in particular in Liberia. I thank you for having me here and look forward to taking a couple of questions.
Thank you very much, Senator Flake. I think it really is important that you are here, and we'll take the liberty of quoting you back to yourself in the forthcoming months. I'd like to quickly introduce my wonderful colleague, Amanda Glassman, who's a fantastic economist and the director of our Global Health Policy Program, who will manage some questions on your behalf. Amanda.
Thank you very much. Okay, we're going to take 3 questions. Can you please say your name and where you're from, and then we'll package them all together and turn them over to the senator. Middle of the center.
Being here, Keith Martin. I'm the Executive Director for the Consortium of Universities for Global Health. I wonder if the committee would actually take on the challenge of using the infrastructure that exists right now and building on it to develop the long-term primary care, public health, and access to surgery that is needed to be able to address this challenge. Before Ebola, there was one doctor for 100,000 people. 39% of the children were stunted. There's massive lack of capacity and infrastructure within the public service as well as on the ground. If we can use the existing relationships that's coming out of this crisis, then we can help the Liberia, Guinea, and Sierra Leone to build the capabilities and capacity that's vital for that foundation to attract the foreign direct investment and for the country to build its economic and social capabilities. Thank you.
So one question about the strengthening of health systems. Do you want to take a response right away, or shall I collect 2 more?
I'll take that one just for a second. That's something that we discussed in our office with Minister Moore yesterday. You know, Liberia lost, 178 health professionals, mostly nurses. Others obviously moved to other areas as well. We started with a situation, 1 doctor per 100,000. Obviously, we've got to have a different situation moving ahead, and it only makes sense to take advantage of some of the structures that have been put in place to address that need. So yes, I do think that who was it that said that you never ought to let a crisis go to waste in terms of taking advantage, and there are cautions there that ought to be stated up front. And we can't sustain the type of infrastructure that's going in now, nor should we. It's not conducive to long-term sustainable care. But we've got to take advantage of the focus that the world has right now on the situation, and to the extent that we can use university system and other health systems to supply those who can train in country and keep doctors in Liberia, we should do that. And we had some discussion about that yesterday. So I'm sure the committee will address that.
Okay, great, thank you. Go ahead.
Senator Flake, thank you very much for being here today. Steve Cashin. Senator Flake, thank you very much for being here today. Steve Cashin with Pan-African Capital. We're one of the leading investors in Liberia and the first American investor in after this administration. We're very excited about the focus of the U.S. and couldn't agree with you more as it relates to the importance that the U.S. had in terms of resolving this situation, as well as the efforts to bring about peace in Liberia over the last 15 years. Has there been any consideration given to the idea of establishing an enterprise fund or a similar type of fund to trigger growth within the key growth areas of the economy? There's been a lot of investment in the oil sector. There's been a lot of investment in the mining sector, a lot of investment in agriculture. All of these areas need a reboot in order to really take off. Has the U.S. considered looking at a pool of capital that would invest in private sector growth, specifically targeting those companies that have invested and are willing to continue to invest?
Well, I think it's an excellent idea. Obviously, for any of those, the industries that you've talked about, to move forward, you've got to have the infrastructure in place, particularly transport to the ports in terms of trade. And that's an area that there's going to be a lot of focus on. But I would certainly love to get with you and have our office touch base and perhaps have a hearing early on what that might look like. So great suggestion. Thank you.
Great. One last question? Because if not, I have a question. This week we've been reading about reports in Haiti of, maybe disappointing effects of our huge aid efforts after the earthquake there. How will we manage our aid differently so we know how it's being used, what its impact might be? What suggestions should we be giving to USAID in this space?
That's a great question. We're 5 years into that, and we had discussion in my office yesterday about that as well. And there's some concern in Haiti that all of the outside aid crowded out private sector activity that would have been and has to be vital to long-term sustainable development. We need to make sure that that doesn't happen in Liberia or the affected countries. So I would think that it is a cautionary tale. It's only the last example of many that bear out the same problem, where there's a lot of focus. We go in, but we don't mind to build up the private sector and make sure that that level of activity can be sustained and carried forward, because at some point the aid goes away. You want a sustainable system. So I think that points up exactly what we were talking about. Let's make sure that whatever form our assistance takes, the primary goal is sustainable economic development. And that has to involve building up the private sector, utilizing the private sector that exists, building it up, shoring it up where it doesn't, and then it can go forward.
Great.
Thank you, and thank you for having me here.
Thank you, Senator Flake.
Well, thank you very much, Senator Flake. I think we'll remember that you said the bottom line is promotion of economic growth, including through the right kind of support for the private sector. I now have the great additional pleasure of introducing someone who's become a friend of the Center for Global Development, and that is Gyude Moore, who has recently become the government of Liberia's Minister of Public Works. Until December, just last month, Minister Moore served as Deputy Chief of Staff to the President of Liberia, Ellen Johnson Sirleaf, as well as head of the President's Program Delivery Unit. So you can tell he sounds like a person who has been and will be accountable for getting stuff done. Since the Ebola outbreak hit, Moore has been a kind of emissary, particularly to the US, I think, for his country and his president in ensuring that more people here understand the implications of the disease, the effects on Liberia, and the extent of the challenges now facing the country. You may have read, and I encourage you to go back and read on our website, blog posts, compelling accounts by Gyude Moore about what has been going on. In his role as Public Works Minister, Moore has a big task ahead, building and rebuilding the country's infrastructure. He was just explaining before we started this event to me a program that I love the title of, Roads for Health, or Roads to Health. He'll talk about it, I'm sure. Before I turn the microphone over to Gyude, I want to tell a small story, something we're very proud of. About 7 or 8 years ago, when the new government, the new democratic government, came to Liberia, the chairman, then chair of the Center for Global Development Board, Ed Scott, promised something to President Johnson Sirleaf. He said, I'll do something. He put a nice sum of money on the table, and after discussion, it was agreed that there would be a program called the Scott Family Fellows Program, under which, through staff here at the center, I think in the first year maybe a dozen young professionals were recruited to act as special assistants, in effect, to key officials in the Liberian government. I remember being heartened and amazed, actually, that at least half of those who applied were of Liberian heritage here in the US and or Liberians living here. In any event, Gyude Moore was one of those selected in the early years, I think about 2008, to participate in that program. It was an incredibly inexpensive program, and we see the fruits there of a kind of investment both in the people that benefited from it as fellows, but also for Liberia, because ministers in Liberia in the early years after the Civil War, they didn't have people to, type up the minutes or prepare an agenda. So I think, it's an indication of the kinds of investments that we can make from here that matter in the very long run for development in other countries through human capital. So it's with great pride that I give the floor to Gyude Moore.
Good morning. It's really good to be back here. I actually have to keep my phone here just in case the Maryland Health Department decides to call me because do the Ebola checks. Because if they call me and they can't get me for 2 hours, they're gonna go to my house, and we don't want that. But it's really good to be back in Washington. I see a lot of my friends here. I went to the School of Foreign Service at Georgetown University, and some of my classmates are still here. And then Mr. Cashin. Mr. Cashin is a very important figure in my being here today. When I was first recruited as a Scott Fellow and offered the job, I turned it down because I wasn't ready to go home. And about a week later, he called me and said, "Look, we don't usually do this, but we think it would be a good fit for you to go back home." And I think it was one of the best decisions I've ever made in my life. Very happy to be here this morning. First, on behalf of my president and my people, I just wanted to say how grateful we are to the government and people of the United States. It is when I was here in September, the conditions back home were different, markedly different from what they look like today. People were dying outside Ebola treatment units because there were no beds. Today, the Ebola treatment units are operating at about 10%. And the US response was so big and so unprecedented, I think it spurred the rest of the world to respond as they did. And we also thank, I mean, most times the credit goes to the president, right? Because he's head of the government, but the US Congress has been there bipartisan for the Liberian people, and for that, we're very, very grateful. So around that time, the president wrote a direct appeal to President Obama and shared that letter with members of Congress, and the Minister of Defense was here, and he said at the time that Ebola posed a threat to the very existence to our state, and he wasn't being he wasn't exaggerating, and what happened after, again, is recognition of U.S. leadership, and again, we're grateful for that. Where are we today? Things are much better today in Liberia than they were. Like I said, there are 9 counties that have had no cases for the past 27 to 29 days. There are 6 counties now where we're still having cases, and those cases, at least 4 of those counties, are being infected by Monrovia, by the capital. 56% of the new confirmed cases are in the capital. And now we're going 2 days, 3 days a week with 0 confirmed cases. So we'll have an Ebola treatment unit with capacity for 100 beds, and they will have 4 cases, 2 confirmed. And that's what it's like around the county. Every now and then, we get 7 infected, 19 infected, and that is because it is very, very difficult to get people to stop ritual and traditional practices that unwittingly serve to advance the disease. And so people, in places where there haven't been infections, people are still doing the ritual preparation of bodies, and that is, in effect, causing more family members and people to get infected. And like I said, Monrovia is infecting the outlying counties because, so if I get sick in Monrovia, then the family says, no, it's not Ebola, it's 3+ malaria, it's typhoid. And then they take him to the village, and then the people who care for him in the village get sick, and then we go in. But we're on the new campaign now. There's no new cases. We said no new cases by the end of the year, but the last day of the year, there were no new cases in the country, even though that's not what we meant. We're hopefully in this quarter, in this first quarter, to end Ebola in Liberia. Unfortunately for us, we're going to live with Ebola for the foreseeable future. The disease has an animal host. If it were just a human host, then with the death of the last victim, the disease would be over, but we can't wipe out all the animals in Liberia. So like Uganda, like the DRC, we're going to have future recurrences of the disease. But I doubt Ebola will ever claim as many lives as it did again. First, a big part of that was just ignorance of the disease. We had never experienced this in West Africa at the scale we did. And initially, nobody knew what to do about this disease. And patients presenting symptoms that resembled malaria and typhoid and Lassa fever, stuff we're used to. And so going forward, Ebola is going to be one of the things that our health system checks for when a person comes to the hospital sick. Going forward now, what next? Liberia after Ebola. I have some ideas, and I hope I can share them with you today. First, initially we had thought that when we got to the day where there was 0 cases throughout the whole country, like no Ebola patients in all of Liberia, then we could begin the economic recovery. That is impractical, and that is not going to happen. The economic recovery has to begin now. Ebola has just completely wrecked our economy. We were projected to grow about 5.4, 5.5% this year. The last projection they did was the Ministry of Finance working with the IMF was minus 0.4. This is tragic for a country where before Ebola, more than 80% of the people lived on less than $2 a day. You can imagine what it's like now with livelihoods cut off because of that. The economic recovery cannot wait. And the economic recovery will have to be centered on the private sector, without question, because that's the only way the economic recovery will be sustainable. And on that, we have some ideas too. But in terms of Liberia after Ebola, the first and foremost thing we have to do is to rebuild our health system. And the tragedy will be for the health system that succeeds the Ebola epidemic to be weaker or worse than the one that Ebola destroyed. So the health system has to be resilient. And there is a plan. After the genocide in Rwanda, the Clinton Health Initiative worked with the Rwandan government to develop this 7-year plan. There's a consortium of 26 American medical colleges and universities that provide, on a rotating basis, faculty at Rwandan health medical schools to train Rwandan doctors and nurses. We've developed a similar plan for Liberia. Right now, it's about $270 million, and it's for 10 years, and the intent is to rebuild the health sector, beginning first, just think of it as a pyramid, and at the bottom of the pyramid are community health workers, and to train about 25,000 of them. These are the people who are the first line of defense. Someone gets sick in the village, this is the person to go to. And Last Mile Health and Dr. Paul Farmer's group are working with us on that. At the second level will be nurses. And I think it's around 8,000 nurses that are gonna be trained. And then above the nurses, we have doctors, but generalists, and then at the tip of the pyramid are specialists. So this program is being developed by the Ministry of Health. It also includes building the Tubman National Institute for Medical Arts. That's where nurses and physician assistants are trained, and then the medical schools at the different colleges, at the different universities, especially the University of Liberia. We're also trying to establish the same partnership with about 26 to 30 U.S. medical colleges, medical schools, so that again, on a rotating basis, they have medical staff, instructors in country training Liberians to be able to do that. So that's in terms of the health system. And now that we're talking about the health system, I can talk about my signature program, which is Roads to Health. And I would like to use, there's a hospital in Liberia called the Jackson F. Doe Hospital. It's in north central Liberia, Tapita, and it's a quintessential illustration of the problem with our health system in Liberia. It costs $10 million to build. It has over 171 different kinds of medical equipment, including the country's first and only CT scan, and they're actually bringing now an MRI. They have specialists from Egypt working there and from China and Liberians working there. So compared to anything in that part of the country, in the whole country and that part of Guinea and Ivory Coast, this is a state-of-the-art hospital. Unfortunately for us, this hospital is not having the effect that it should. 6 to 8 months out of the year, it's raining in Liberia, torrential rains. 90% of the roads in Liberia are unpaved, and in the middle of the rain, it is impossible to access this hospital. So you can have a state-of-the-art facility that is not very useful to the people it should be benefiting because they don't have physical access to this. So as we build a health system after Ebola, we can build health centers all across the country where they weren't before. But we have to build a health system that functions in the rainy season. And to do that, then physical access has to be considered as part of the health infrastructure. And so in Roads to Health, next week, actually they might do it before I get there, although I'll be upset if they did before I get there. The Ministry of Public Works will be rolling out the first phase of Roads to Health. And we're beginning with Monrovia. Like I said, about 56% of the new cases are coming from Monrovia, and they're from overcrowded communities. Monrovia was essentially built for about 350,000 people. Now it has about 1.5 million people. So people live in these crowded communities with no egress or very little egress or ingress. And so I sent out 4 teams of 12 engineers into all of those communities to do an assessment of the conditions of the roads. And we're gonna do, and so it makes it easier. If ambulances have to go into communities to evacuate people, the riding surface will be better, and in the rains, it will remain accessible for them to be able to do that. Because Ebola is transmitted through contact with body fluids of sick people, We want professionals evacuating sick people, and that's why. And the Roads to Health is a multi-year program. It takes a second tier of roads, because initially for our agenda for transformation, we had selected the main corridors that we wanted to develop. But Ebola, of course, exposed weaknesses in that. And so there's a second tier of roads that will ensure access to health facilities year round. We also have to talk about power. We worked with the MCC and we did a constraints analysis for Liberia. What is the binding constraint to economic growth in the country? And we found there were two: roads and power. If Liberia's economy is to recover, something has to be done about power. Let me just give you an example. The president did an op-ed where she said that on game day, the Dallas Cowboys stadium uses more electricity than Liberia has in installed capacity, and that's true. And this year, we have about 22 megawatts of installed capacity. The 22 1 megawatt generators, the kind you find behind big hotels, so that when something happens, they turn them on. Well, this year, we should have phased out some of them. About 12 of them were given to us by USAID. And these generators weren't meant to be the primary source of power. So they're ready to be, but because of Ebola, we were trying to build heavy fuel generation capacity, but all of that has stopped because of Ebola. And again, we have to come back to Liberia's weather. When we lose the dry season, we've lost a full year, because it's only in the dry season that we can do any substantive construction work. And so we've lost at least 15 to 18 months already in Liberia. So there's roads, there's the health system, there's roads, there's power. And then we have to focus on the private sector. Currently in Liberia, most of the investment is in agriculture, mining, especially iron ore mining. But anybody who's been following commodities prices knows that there's been a huge dip in the price of iron ore. All our economic projections were done with the intent that our iron ore companies will be expanding, but even they now have to curtail their ambitions, and that has implications for our fiscal condition. And so here's a suggestion of what we could do in terms of the aid that comes to Liberia as a response to Ebola. Maybe Liberia can offer some of these companies a tax break, a tax incentive. Well, the monies we would have collected in revenues from them from taxes were monies that would have gone to pay teachers, pay doctors and nurses. Last year, when we had issues with collecting money, USAID gave $5 million to help cover the salaries of health workers. And so if we give the tax incentives to these companies so that the private sector remains viable in Liberia, then what we lose in that can be made up for in terms of what comes to the country, whether it's to support education or to support health. It's just an idea on what we can do with that. I also wanted to talk about accountability. Obviously, one of the things that people want to know about, and every time you open a newspaper in Liberia or listen to the radio in Liberia, there's somebody on the radio talking about corruption, and I think that's a good thing. I think one of the things that President Sirleaf's administration has done has opened up the country for people to be able to talk about corruption all the time. So obviously, it seems like this administration is more corrupt than the ones that came before it. I think it's just because of the sunlight, people can talk more about corruption now without fear of being arrested or jailed or worse. And a few months ago, I wrote a piece responding to some bloggers who do health reporting, and Amanda helped me and published that on the Center for Global Development website. I'm saying all this to say that first, in terms of accountability, there's a lot of money going into Liberia right now for Ebola, hundreds of millions of dollars. And at some point, somebody has to account for this money. The government of Liberia, I think it should be very clear that money is coming to Liberia for Ebola are not coming to the government of Liberia. The monies coming for Ebola are going to WHO, MSF, WFP, and they have to account for that money. The Minister of Finance has requested every institution and entity in Liberia responding to Ebola to give an account of how much they've received, what they've used it for, so that we can be able to publish that. UNMIR, the newest UN agency that was established to fight Ebola, is supposed to create a platform for everybody to be able to publish on there what they're doing with monies coming to Liberia. The reason this is important is this. 2 years from now, some blogger is going to write an article and say, this is a country that receives $3 billion in aid, and look what they've. Technically, they're correct, but that's devious, right? Because the money is not actually coming. It's not actually coming to Liberia. And in terms of Ebola response, the infrastructure to respond to Ebola does not translate into permanent structures. Most of them, they're tents. We can actually, it's going to be very difficult to imagine a more permanent use for what we're doing in terms of responding to Ebola. And so what we can do, though, is to marry Ebola response with our regular health system so that we can make the transition easily. And so the president has insisted that these things so in the Ebola, I'm going to close shortly, but in the Ebola response, they have a forward logistic basis. When material comes into the country at the port, like PPEs and chlorine and drugs and whatever it takes to fight Ebola, they're taken into 5 warehouses, you can call them. These are the 4 logistic bases, and the country has 15 counties. So each FLB manages 3 counties, right? 3 times 5? Yes, okay. The whole point is that these 5 logistic bases will become future sites of we have a national drug services that supplies public hospitals. So these sites will become the future sites of regional depots for the National Drug Service. That way we can transition from an Ebola response to regular health. The president has also insisted that there's a second stage called community care centers. And community care centers are basically isolation places. If someone gets sick and we don't know if it's typhoid, malaria, or Ebola, we take the person away from their family and put them in a CCC. They take a sample of the blood and send it to the lab. If it turns out that the person has Ebola, the person is sent to an Ebola treatment unit. If the person simply has malaria, they're sent to a regular hospital. And the president insisted that the CCCs be of more permanent structures and they be built next to Ebola treatment units, next to hospitals, so that they can in the future be used for triage. Hopefully, that will be something that stays after Ebola. But when a country goes through what we've gone through, first there was the war, then there was the second war, that's Ebola. It is impossible for the country to remain the way it was before. And so a lot of things will change in Liberia. Here, when I'm in the US, I have to get used to shaking people's hands again. In Liberia, we just bump like this, and that's become normal now without and so even in how we grieve, how we take care of the sick, all of that is going to change. And as Liberia changes, I believe that our partners should also change. And I have a couple of comments for our friends at the World Bank, the African Development Bank. One of the biggest industries in Liberia is road construction. I'm Minister of Public Works. And I was just saying to Nancy that the credit to GDP ratio, which measures the commercial banks lending to the private sector, is around 20% in Liberia. In the US, I think it's around 168 to 200%. You want that number to be high because it is a reflection of the activity happening in the private sector. Almost half of that is commercial banks lending to construction companies. Mr. Cashin owns one of those commercial banks in Liberia. But the way the pre-qualification criteria are written for World Bank projects, it makes it absolutely impossible for a local firm to ever participate in a World Bank. For example, they might ask for 75 to 100 million in annual turnover. If you put all of the construction companies in Liberia together, I doubt they have 10 million, let alone 100 million. But this is what happened. Almost all of the partner-funded projects in the country came to a halt with Ebola because every one of them is done by an expat company, and they invoked force majeure and fled the country. Now, if those projects were designed so at least 20 to 30% of the works were subcontracted to a local firm, some works would have continued because the locals, they don't have anywhere to go. Even up to today, it's difficult to start the projects. The Chinese companies are coming back, but some of them, the monitoring consultants, are from New Zealand and South Africa, and those countries have restrictions on travel. And so the monitoring consultant cannot come, and we have to wait until they come for these projects to go forward. Similarly, I would like to say, just as Ebola revealed weaknesses in our systems that need to change, they have exposed weaknesses in the international system in how these programs are managed, and those programs also have to change. Thank you.
For a panel now. I invite our panelists to join us. Jeremy Conadic is from USAID, will be joining us shortly, and we can. Okay, let me get my own. I forgot my question. Okay, well, thank you, Minister Moore. That was, I think you ended on exactly the right place. We all need to change to get more effective. And so it's only fair, since you posed a question to the World Bank right at the end, to ask our World Bank colleague to tell us a little bit, Chico Ferreira, who's the chief economist for the Africa region at the World Bank. They've been working very extensively on estimates of the economic impact. So I'd like to ask him to say a few words about that work, but also maybe to comment on the issues that Minister Moore has just raised. So
Sure.
take it away.
Thank you, Amanda. Thanks very much for the opportunity to be here. It has been a great event so far to listen to Senator Flake and to Minister Moore. I wanted to make 5 brief points, and at the end I'll come back to the question that Minister Moore just raised. So the first one is to sound a note of caution on the title of this event, which is Liberia after Ebola. So I was here not long ago with my colleague Dave Evans and Amanda and a number of other people at a roundtable that discussed this issue. And I think there was wide agreement at that meeting that the time was right to start thinking about after Ebola. But as I said then, and I'll say again, without taking away the focus from the fact that we're still very much in the during. It's fascinating and incredibly heartening to listen to the minister's reports of how things have improved in Liberia, and they certainly have dramatically since September. But the latest numbers that we had are still of the order in the last 21 days. The last report I had is of the order of still 448 cases in the last 21 days and 139 deaths. Okay. Now, we heard from the minister how there's still cases appearing here and there, and I'll come back in a moment to the nature of the economic costs and why it is important to keep the eye firmly on the ball, and I'm sure that the government of Liberia is doing that, to borrow the phrase from my big boss, the President Jim Kim of the World Bank, go to 0 cases. Okay, so this is fundamentally important. And Minister Moore referred to the challenges that are posed by the animal hosts. I think an equally important, if not larger, challenge is the fact that these 3 countries are really kind of very deeply interconnected: Guinea, Liberia, and Sierra Leone. And the situation, unfortunately, in Sierra Leone in particular, is nowhere near as good as it is in Liberia. There, the number of cases in the last 21 days is over 1,000 cases and a large number of deaths. And we know that people travel between these 3 countries all the time. That's how it first spread from Guinea to the other 2 countries. And there have been substantial degrees of reinfection. As Guinea made progress some months ago and had much lower cases, flowed back through travel of relatives, going to burials and other things between these 3 countries. So quite apart from the bats and other animals, whilst the epidemic continues to rage in the other 2 countries, Liberia will face formidable challenges. And I think, of course, the government of Liberia thinks about Liberia, but the international community must think of those 3 countries and getting to 0 cases as quickly as possible in those 3 countries. It'll be impossible for any of these 3 countries to really eradicate the disease whilst it continues to fester in other places. So that's the first point I wanted to make. Let's think about the after, but let's keep quite a lot of attention focused on the during and on the treatment and prevention that are necessary to get to 0 now. My second point relates a little bit to the work that Amanda mentioned, the work we did trying to estimate the costs of the economic impact, rather, of the epidemic, both last year in 2014 and estimates going forward. And this is work, actually, incidentally, that was carried out largely by my colleague Dave Evans, who's sitting somewhere in the audience here, as well as Mead Over from the CGD, who's been working very closely with us since in this panel, and a number of other colleagues. And one of the things, I won't get into all of the numbers and so on, but one of the things that we found out as we were looking at the economic impacts is that the economic impacts of Ebola, of course, they reflect to some extent the medical costs, the costs of foregone work by people who are sick or who unfortunately die. But the largest costs are actually not from those things. The largest costs are from what we call aversion behavior, which is probably a fancy word for fear, and often very well justified fear and aversion behavior. So what happens, and we have recently a number of surveys that have been done that confirm this. What happens is that places of employment close. It's harder to get people to farm together in groups because there's a fear of farming in groups. Demand for all kinds of services and commodities decline. Mines didn't typically close so much, but they postponed or canceled investments going forward. So there's a general effect through economic activity that caused, we heard the senator mentioning earlier how, and I think the minister also mentioned how growth in Liberia was of the order of 5 or 6% before this epidemic, and in fact was forecast to be in the order of 5 to 6% in 2014 and 2015. Instead, it was, by our latest estimate, 2.2% last year, and the forecast for this year is of the order of 3%, already reflecting some of the improvement that we've been seeing. But if you add up the foregone growth, the output that Liberia would have produced and didn't because of the epidemic, that's of the order of $250 million for Liberia alone, which in this, a very poor country is a very considerable sum. If you add the three countries, it's as much as $2 billion, according to our latest estimates, of foregone economic impact. And most of that comes from this aversion behavior. And therefore, the biggest thing you can do to reignite investment and economic activity is to fight the epidemic so that the fear is displaced and the fear is replaced with confidence, right? And just yesterday, the bank launched a new study based on a phone survey that's been done recently. The cell phone surveys that are done by the World Bank together with Gallup and some other partners. There are a number of caveats methodologically about those surveys, so I don't want people to be overconfident on the numbers, but nevertheless, they provide a kind of unique insight by actually talking to people on the ground now about what they're doing. And the reflections from those surveys, that come out are substantial declines in wage employment and self-employment. For those people that are working, lower incomes, okay? And those impacts are not happening only in the areas that are directly affected, but across the country. And the reason is, some of these transport links. It's very hard to move things to Monrovia and so on. So there are, the effects captured by the cell phone surveys spread across the whole of the territory of Liberia, not only the most affected places. Okay? Incomes have fallen, rice prices have risen, food prices more generally appear to have risen. The impact on agricultural employment is actually lower than we thought. Agricultural employment is more resilient, but people who've reported on the harvests that they've had report lower harvests and slower harvests to complete, largely because of this difficulty of having the teams work together in the farm. So it'll be interesting to hear later from the minister whether that matches with the perception that the government is having. That's what's coming out from our current work. That leads me to my fourth point, which is just the one before last, which is when we do think about the after and about the investments for recovering Liberia from this epidemic, what are we thinking about? And I want to emphasize here the importance of rebuilding and protecting Liberian human capital. So we've heard about the challenges on the roads, we've heard about the challenges on the power. I think all of those things are tremendously important, and they were always structural challenges to the Liberian economy, and they remain that way. This epidemic, of course, didn't destroy any roads, but it has the potential to have had a substantial impact on human capital. These are families that were already either in poverty or just near the poverty line. As their incomes fall and food prices rise, the nutrition that Liberian children are having in the poorest parts of the country now must be under threat. We don't have data exactly on malnutrition in Liberia yet. It's very hard to collect that data. Cell phone surveys don't do that, and for obvious reasons, you can't have enumerators in the field. But everything that we see suggests that there's, this increasing poverty could be a serious problem for nutrition amongst children in the poor, amongst the poor in Liberia, which is most of the population. Similarly, schools have been closed for long times. So what education was going on has stopped. So as we think of recovery and investment going forward in Liberia, of course, a lot of the attention is centered on roads, on powers, on involving the private sector. All of those things are good and true, but let's not forget that for the bulk of the people, investing in them and their human capital, particularly in children, is fundamentally important. And there are things that I think the government can do through cash transfer programs, through immediate forms of social protection, trying to reach out to these places. I know that there are conversations taking place about that with my colleagues at the World Bank and others, and I think that would be a very important part. It's easy to think of an economy as centered around just banks and businesses and large mines. That's part of the problem. We want an economy where people are productive, and to have that, you have to invest in them. They've been under severe stress over the last, as I say, both in areas where Ebola has been present and elsewhere because of the economic impacts that I described. My last very brief point, and I was heartened to hear Minister Moore talk about the perceptions of corruption and what the government is doing to deal with them, both the sunlight to air them out and efforts to contain it. The fifth issue that I want to raise is the issue of governance and the importance of that, right? And there is a lot of aid money coming in. As was said before, quite a lot of it is not to the government, but some of it is. And if we're talking about cash transfers, if we're talking about reaching out quickly with social protection and education spending into these more rural areas and so on, it would be very important to keep a very strong eye on the governance and the accountability of how those flows are managed and so on. Lastly, just to respond briefly to the point that was made about procurement rules of the World Bank, I was mentioning briefly to Minister Moore on the way in that I just recently became aware that we're actually having a procurement reform at the World Bank as we speak. Somebody just came over the other day to the Africa region and explained to us they're changing various things in the procurement rules. Not typically something the chief economist pays a lot of attention to, but in this context, seems to be quite important and appropriate. And maybe we can see, I'm not sure whether that particular aspect, the sort of, the requirement of turnover for firms is being changed. But if they're changing the whole thing, maybe we can look at that. So I'll follow up on that, and maybe we can have ongoing conversation with the government through the country director's office and so on.
Sure.
Those things.
Excellent.
you.
Okay, well, thank you very much, Chico. Welcome to Jeremy Konodike, who's the head of the Office of Foreign Disaster Assistance at USAID and is leading the U.S. government response to Ebola. We've had some great remarks by Senator Flake and Minister Moore about U.S. Congress's view on the Ebola response and looking forward in Liberia. Minister Moore has talked a lot about what priorities are for the government and some issues about how we manage aid, how we can minimize distortions and increase accountability, given that a lot of that aid is running outside government. So would you like to say a few words about the U.S. response, how you see the after/parallel efforts on recovery?
Yep, wonderful. Can everyone hear me? I'm convinced I put this mic on wrong.
Yes.
It's much higher tech than I am. So the president has been very clear that this is a huge national security priority for the United States. I can't tell you the amount of White House attention that this has received, much more so than anything else that I've worked on in this job. And there is a really deep commitment to driving this disease to zero in Liberia, but not just in Liberia, in all of West Africa, because we very much realize that it's not gone in any country until it's gone in every country. And so to that end, while we have huge investments now in Liberia to drive this to zero, we've also really scaled up our presence and our effort in Sierra Leone and Guinea. We also sent a a pretty substantial USG team into Mali when some new cases emerged there, and fortunately seems to have dodged a bullet for the time being there. That's not wood,
It's
is it?
not wood. Here.
So I think we're. I feel very confident that we will achieve that, and we will achieve that. I think it's wrong to say actually we will achieve that. I think we will achieve that in support of the governments of Liberia, Sierra Leone, and Guinea, who are in the lead. And I think that's the first critical point to make in terms of the question on how the U.S. plugs in and the accountability question. You know, we are very, very clear that we are in this in support of the government of Liberia, the government of Sierra Leone, and the government of Guinea. And those governments are in the lead. We are there in a support role and an advisory role to help them to defeat this disease. To do that, we've mobilized what is a little bit of a dirty phrase in CGD, I think, Todd, whole of government response to this to this crisis, but the good kind of whole of government response, the really effective kind. And you know, we've done that because we're very clear that no single part of the USG, and we've got a CDC colleague who just walked in over there. No single part of the USG has the capability to do this on its own, and so AID has some very useful capacities to lead this fight, but we don't have everything. We don't have the deep epi knowledge, the deep medical capabilities that CDC has. CDC has world-class, amazing capabilities, but they don't have the operational, the operational and implementation capabilities that AID has. None of us have the logistical capabilities that DoD has. Another critical interagency player has been the U.S. Public Health Service, which is running the Monrovia Medical Unit, the high-end medical facility and treatment facility for healthcare workers and other responders. You know, that capability is pretty unique to U.S. Public Health Service. So you need that package in order to respond effectively. No single part of that can do it on its own. And a really important focus for USAID and for my office at OFDA since the Haiti response in particular, has been to build out our ability to do whole of government work effectively. Clear roles, clear responsibilities, investing in relationships, investing in interoperability, and we're seeing the payoff of that in this response. And it's never easy, it's never perfect, it's never perfectly clean, but it's at the end of the day been very effective. And it's been, we're now at a point in Liberia where confirmed cases in August were 30 to 40 per day. We're now down to a point where that may be as low as 1 per day. So that's huge progress. It also means it's kind of a dangerous time because there's a temptation then to say, okay, we're down to 1 a day, almost there. In fact, we're not almost there. There's a lot of work to do to really extinguish this and have confidence that we've extinguished it. And you don't fully declare one of these outbreaks over until you've been through 2 cycles of the potential incubation period for the disease. So when we see what we think is the last case, and then another about 42 days have gone by, then we'll feel happy. But that whole of government response that I referenced is coordinated through USAID's DART Disaster Assistance Response Team platform. And so when the president said back in October that USAID was leading the strategic backbone of the response, that's what he was referring to. It doesn't mean we're doing all the work, but we're sort of at the center of the web and trying to make sure that all of the pieces are working in sync and in a coordinated way, and not getting in each other's way or duplicating effort or pulling in capabilities that are unnecessary. The trajectory we're on now, I think, is increasingly positive in Liberia. We are feeling guardedly better about Sierra Leone. I think Sierra Leone had everyone very, very scared in November and December. It looked like cases were continuing to climb at a pretty frightening clip. That's now leveling off and perhaps even starting to decline. And we're guardedly optimistic, I think I would say, that we'll start to see Sierra Leone follow a similar trajectory to Liberia over the next month or so with an increasing drop-off in cases. Huge amount of effort and huge amount of work still needs to go in to make that happen. Guinea, we're still somewhat nervous about because while Guinea has never seen the kind of explosive case growth that the other two have seen, it also continues to spread into different parts of Guinea and pop up in different areas. And so we've made additional investments there. The French have made additional investments there. The UN has made additional investments there. Those are starting to come to fruition now. and we're hopeful that that will pay off. But then the big question of what this is more focused on, this event I think is more focused on, is what comes after all that. So say we get to, I'm not going to name a month, but let's say we get to some month later in this year, and we've seen what we think is the last case. What needs to follow on? Well, what needs to follow on is what is now starting. We're not going to wait until that last case emerges. We need to invest in a few areas. We need to invest in building out stronger healthcare systems. That's very, very clear. But not just stronger health systems, but healthcare systems with different capabilities. Because these healthcare systems could have been a lot stronger than they were. They still would have had trouble with this disease because they'd never seen it before. And it's a very pernicious disease. It looks and acts in the early stages a lot like a lot of other diseases in that part of the world that are much more common. And that was one of the things that enabled it to go as far as it did before it was recognized for what it was. So we need stronger healthcare systems, yes, in general, that's clear, but also healthcare systems that have greatly improved infection prevention and control, and protocols and systems for recognizing and dealing with this sort of disease. We need stronger epidemiological surveillance, disease surveillance systems, so that we can recognize this sort of thing for what it is much, much earlier on. If this had been recognized in the first month as opposed to the third month, it would have been much easier to contain. So a lot of work to do in the health sector. But also there will be serious economic impacts of this. Probably not in the long run huge macroeconomic impacts out of this, but a lot of microeconomic impacts, a lot of household level and community level impacts. Families that have lost caregivers, have lost breadwinners, children who've been orphaned, communities where a huge amount of the population has been wiped out by this disease. There are going to be a lot of those sort of impacts that are going to endure, and will need support going forward. A family that's lost its breadwinner, a child that's left without parents and is stigmatized, is going to have a very hard time, is going to need assistance, but smart assistance. We need as well to ensure that the economies of these countries in the short term, and I think you were touching on some of this when I came in, the economies of these countries in the short term are stabilized so that the hit that they're taking in the near term doesn't translate into some longer term damage.
Mm-hmm. Okay, well, thanks very much, Jeremy. Mead has been working on the economic impact models with the World Bank team, but he's also had the opportunity to attend a meeting at the World Health Organization a couple weeks ago on health system impact. And as a good health person, I have great fantasies about what could happen. And we all talk about a better health system. But in reality, how much money is available per capita? How would that financing be organized? What are we talking about when we talk about better health systems or better health response? Mead?
So that's a good question. And the comments beginning with Senator Flake and Minister Moore and the subsequent comments by the other panelists have all talked about this a little bit. And I want to put out what I think is probably a fairly provocative proposition. The question, as Amanda raised, is how should health systems be strengthened in West Africa and in Liberia particularly in order to prevent another Ebola epidemic? And that question was addressed by the meeting I attended in Geneva, December 10th through 12th, by ministers of health and of finance, including some of Minister Moore's colleagues from Liberia, and also their similar people of similar rank and authority from Guinea and Sierra Leone. And there were representatives from all the major donors, I would say, including the World Bank. Some of Chico's colleagues were there. Tim Evans, who's the director of health, for example, was there. And this question was raised, and the discussion was almost entirely about what here I'm calling Model A. We need to put a lot more money, people were saying, into developing the health systems of the West African countries so that they look a lot more like American health systems. And when I was sitting there and scratching my head and wondering what they meant, I was wondering if they meant for the health systems and the hospitals of Liberia, for example, to look like the Presbyterian Hospital in Dallas, Texas. Well, the Presbyterian Hospital in Dallas, Texas, in fact, was not able to prevent nosocomial transmission of the disease once a case arrived. And also, I want to point out that the outbreaks that have occurred in Uganda and in DRC over many years have occurred but been quickly isolated. And I think it's important to ask how those countries have learned to be able to control this epidemic, to first of all, identify it quickly, and secondly, respond quickly in order to quarantine people without very strong health systems. So given the fact that that has been possible, the question is, why was that not possible in West Africa? And Minister Moore pointed out his extraordinarily nuanced and detailed remarks were fascinating, I think, to all of us. But one of the things he discussed was the fact that people of West Africa had never seen this disease and actually didn't really believe in it. So that reminds me of the early days of HIV, when people in Africa didn't believe in HIV. And it took some time for people to become aware that this is a dangerous disease. But the question is that given that awareness now, what sort of strengthening of the health system is might be sufficient to prevent the next Ebola outbreak, and what sort of what should we argue is actually necessary to accomplish that objective? So the next slide is a slide. Next slide, please. Yeah, the next slide was prepared by David Evans at WHO, not David Evans of the World Bank. David Evans of the WHO is the head of the economics and policy unit there, and he made this slide in order to argue that the overseas development assistance that's been flowing into the 3 affected countries has been misaligned. The slide points out, and you see the part in blue is all for vertical programs. The part in red is the overseas development assistance that's gone into strengthening the health systems. He did not say so quite so definitively as I will now say it, but I think he was arguing that if this had been different, if all of this money had been in the red category of general health system strengthening, the Ebola epidemic would have been prevented or greatly, or have had much less impact. I don't think that's well established at all. I do think that there are strong reasons why foreign donors preferred to put their money into vertical programs, and those reasons have to do with accountability. Mr. Moore talked about accountability, and Amanda asked Senator Flake about accountability. Accountability, we were talking about accountability for where the money goes. But in the more fundamental sense, accountability is to try to get health benefits for the money that's spent. And the reason that donors prefer, in many cases, to put their money into vertical programs is exactly because of the vertical accountability mechanisms that can be designed into those programs and can assure that the health benefits actually accrue. So with that in mind, how might one go about thinking about a health, strengthening the health system so that it could, in this Model B sort of way, where in fact you could have very strong disease surveillance capability to be able to detect a new outbreak of meningitis, of cholera, of Ebola when it occurs, and then have a response of the sort that we now know is necessary. So the next slide will be one that's very familiar to Minister Moore. This is a map of all in the red dots are all the health facilities in Liberia. The green dots are the Ebola treatment units that had been in place late last year. I believe they're somewhat more than that now. But strengthening those health facilities by simply trying to raise them to the standard of the Presbyterian Hospital in Dallas, I would suggest is not the answer. I'd very much liked Minister Moore's suggestion of roads to health. Many of these red dots that we see on the map are completely isolated because of the lack of transportation. And so clearly, I would put strengthening those roads as one of the inputs that's necessary, if not sufficient, to prevent the next Ebola epidemic. But then I would argue, the last slide, I would argue that more than that, there needs to be some kind of regional strengthening, not only of surveillance, and I very much like the idea that you say President Johnson Sirleaf supports, which is to maintain the CCC units in order partly to act as a buffer for the existing health center so that they can feel more confident when they accept patients to them, and also because the CCCs are serving, I believe, if I understood you correctly, as a first line surveillance network, and they're collecting information and passing it on to the ministry. I would, I tremendously support that as what I would perceive as a necessary way to strengthen the system. But I wonder if, in order to be sufficient, there needs to be a regional mechanism that does what each individual Ministry of Health is now doing. The people in the hazmat gear and the protective suits who come in on hopefully your strengthened road system in order to identify whether people are truly Ebola cases that need to go to a treatment units or not. Those people might come from a regional source. Now, in April of 2014, the African Commission proposed at a meeting organized by the World Health Assembly in Africa that there be an African Center for Disease Prevention and Control, ACDPC, right? that the African region of West Africa have that capability, which now exists arguably only in Atlanta at the Center for Disease Control. And I support that as a possible solution, which together with this strengthened on-the-ground surveillance could actually be both necessary and arguably sufficient to prevent the next Ebola epidemic.
Okay, well, thank you, Mead. I just want to point out that this is not a World Health Organization slide, in case Mead was using some old template.
I used
This is
I
not
used David
actually their
Evans'
view,
slide,
correct?
and then unfortunately I dropped mine on top of it.
Okay, just so
Background's
that
still
our
there.
poor colleagues from the WHO don't have a heart attack. What? Minister Moore, so you've had a round. You've heard what others had to say. We've also put out a draft of an open letter that tries to summarize some buckets of response priorities in the recovery period. We're talking about households, just getting households back on their feet, dealing with these nutrition and early childhood effects, health systems. We've talked about that. I have less clarity on what that actually means, whether it's just this regional disease surveillance and rapid response mechanism, or whether it's something more comprehensive to support the recovery of the health system of Liberia and its neighbors. And then a third category, which has to do with firms and economic recovery more broadly. So what are your reflections after hearing everyone's 2 cents, all the work going on?
Sure.
Thoughts?
Is this thing up?
Yes, it is.
Okay, great. Yes, so first, definitely we have to recognize the regional aspect of the outbreak. About 2 months ago, there were a couple of incidents across the border from Liberia in Guinea, and we sent our right teams, and the right teams are the basically rapid response teams, and they went over into Guinea to try to do it. And there's already precedent with the three countries working together. We have a flight information region, so Liberia, Guinea, and Sierra Leone, so that flights entering the airspace of the three countries, we collect the information and we share the revenue that comes from that. So there's already precedents in place for the three countries cooperating on information sharing. So something like that, like regional surveillance, would work for the three countries. And like he said, even if we were to get to 0 cases in Liberia, because of the long and porous borders and the family relations across the borders, it is going to be very difficult for us to keep from reinfecting each other. So the three countries will have to be considered together. Unfortunately, I'm a minister in the Liberian government. That's what my concern is primarily. But we should definitely see the regional implications of this. On the issues of the numbers, again, I think there is healthy tension between us as the government and those responding to it. Because when we hear the numbers are aggregates, and there's an aggregate of confirmed, suspected, and probable cases. And so when you combine the aggregates, it sounds like a bigger number. Again, we're at no place as a government where we think that the crisis is over and we should step away from the crisis now. We're still, one Ebola case can generate 100. And so one Ebola case present in the country remains a threat to our country, and we will not stop. We'll continue to be vigilant. Our thing is to ever get to a place where we've gone 42 cases without 42 days without an Ebola case, for the WHO to announce that Liberia is now Ebola-free, for that to be the starting point of our economic recovery is to ruin ourselves, and we're not going to do that. Also, this year, like some people have said, it's 5 years since Haiti. And the whole an advantage to being a human being is that we're heirs to this body of knowledge so that we don't repeat the same mistakes. And going forward for us in Liberia, Guinea, and Sierra Leone, we're trying to be very cautious in terms of how the response is managed because of the food insecurity problems, because of the loss of livelihood. There is a strong and current need, continued need for NGOs and a response in that manner. But the economic response cannot be led in that way. Otherwise, Liberia, Guinea, and Sierra Leone, 3 years, 5 years from now, would be where Haiti is today. We will have to balance that with strengthening the private sector. If people have jobs that they go to and get paid for it, if people are able to generate wealth working, that is the only way the economic recovery will be sustainable and robust. Um, in terms of money coming to the government, we have, I promised yesterday that I would check. I think it's PricewaterhouseCoopers. We have hired to do an audit of how we have used money that has come to us for Ebola, and that is going to be published. It's going to be given to the legislature, but it's also going to be published so that everybody is comfortable with what Liberia has done with monies that have come to Liberia. As for monies that do not come to Liberia, we can only encourage our partners to be as open as we are in how the money is being used and how it's been expended. But in terms of the cash transfers, I think that will work in a place like Liberia, especially for livelihoods, and it should be something that would be encouraged. Now, how would it work? The U.S. government has this really awesome thing called FARA. I
Fixed amount reimbursement agreement.
Outstanding. That's it, right? And what they do is basically they come into the Ministry of Health or come into Public Works. My predecessor signed an agreement with USAID, and so they're going to start with us shortly. But they come into the ministry and assess the strength of your public financial management system. And then where you have weaknesses, they propose a whole slew of interventions to strengthen it. Once it becomes strengthened, then they do these reimbursements. So money is coming from the U.S. government will come to you, but as reimbursement after it's been proven that you met the benchmarks and done what you've done. And they've been supporting the Ministry of Health in Liberia with that. They're signing these agreements with other ministries and being able to do that. I think that is an excellent model because what it does in the long run is strengthen the capacity of the ministries and agencies that you're working with so that their systems is actually the people themselves that are running the systems. So I think in terms of cash transfer and governance, that will be and then we're opening schools on February 2nd. We've gone almost a full year with our school, but we're doing all the prep work, water stations for kids to be able to wash their hands and everything that needs to go there, having nurses at the school so if a kid shows up with a fever, what to do. They so and second to the last thing is how can we use Ebola to strengthen our health system? So currently, every morning, there are calls into the incident management system. The county health teams will call and say, oh, 3 persons were sick. We tested one of them. Is negative, but we're waiting 48 hours to run the second test. So now in that case, it's a possible suspected case. And every county will call in. Every day they do this. Is it possible that the health system that comes after this, instead of calling simply about Ebola, they can be calling numbers with malaria, cholera, and it's a very simple process. It doesn't have to be a very complicated system. Every morning, people call. Now, the second thing is the incident response has been broken into county health teams. So now they only depend on Monrovia if the case become more than the county health team can do. But in most of these instances, the response is coming from the local level. That also is a resilient health system because now response can come from the local team. And my final thing is that as for a country like Liberia and countries like our brothers and sisters in Guinea and Sierra Leone, at some point, the conversation about donors will have to end. I mean, it's very difficult for people to respect you when they feed you. It's just part of the human experience. And at some point, we have to be in a position where we can provide for ourselves, we can do things for ourselves. And the way to be able to do that is to be able to build our economies, is to be able to add value. As long as Liberia, Guinea, and Sierra Leone continue to export logs and iron ore, we're 10 years from now, 20 years from now, we're going to be back in the same place. We can use this Ebola outbreak and the economic recovery after this as an opportunity to begin to invest in the private sector in these countries in such a way that is a resilient, and I keep coming back to resilient and sustainable. Because the thing about aid is whether you like it or not, no matter how well it's crafted, eventually people become dependent on it. People develop skills that the system rewards. And if the system rewards those who write very good grant uh, proposals, then those are the skills that people develop. And so we look forward to a bigger role for the MCC in Liberia. The MCC, with its focus on the private sector and infrastructure, will be a significant partner. I'm not just saying that because Evan is here.
But he is here.
Oh, yes, yes. But that and the ability to be able to match, Steve talked about an enterprise fund, maybe even for the Liberian diaspora, so that you mirror what happened with us as the Scott Fellows. I, 5 years ago when I left DC and went to Monrovia, I did not think I would return as a minister in the government. But the good thing about the Scott Fellow program is that almost every single Liberian who went to Liberia under that program stayed. And whether they worked in the private sector or worked in the government, they stayed. Well, some of the guys got married and left, but you can fault them for that. But they stayed. If we can have a similar program for entrepreneurs in the diaspora who want to go back home and become involved in the private sector, but access to credit is an issue in a place like Liberia. If we can find ways to be able to strengthen those places, I think we'll be able to move forward. I've been talking for a while, so thank you.
Thank you, Minister Moore. That was great. Okay. Let's say we have 10, 15 minutes, so let's go to a round of questions. Right here in the front row, please say your name and where you're from.
Good morning. Thank you to all the panelists. My name is Tiaji Salam Blyther. I'm coming from Congressional Research Service. I want to have a few questions for Minister Moore. I think you gave an outstanding presentation.
You.
You did a really good job at hitting on several points and interlinking them in ways that we often don't. I want to give you accolades on that. And before I do that, I just want to give a small pushback to Mr. Over about the health system strengthening piece. I think that, in the words of Senator Flake, a lot of us health systems people try to take advantage of the outbreak. And one of the things that people who have been doing global health for a while have been frustrated about is vertical programs. For example, you might save a woman from HIV and then she dies in childbirth. And part of that is not because of accountability, but also that's congressional mandates that control how the funds are used. So there's not that flexibility and movement of programs. So that's part of why people are saying, what can we do for the health systems more than just Ebola? You might save them from Ebola and then they die from diarrhea if we don't improve the health systems. So I'm off that soapbox.
Can I ask, when you ask your second question, but just to follow up on that, I mean, is there some thought about, so we now have these two large sets of funds in the form of Ebola and now PEPFAR. We had an earlier effort, the Global Health Initiative, to try and do better joint programming at the country level. I mean, what can you say about that? You should go to your second question, but I just want to make sure that you answer that.
Okay. So in terms of the questions, really quick ones for the minister. First, is the Liberian health plan publicly available? If not, can I email you later and get it? Sounds fascinating. Sure. Second, what is the name of the health training program that you mentioned for the health workers? And the final piece is, what about retention? We know of a lot of instances of health workers being trained and then ultimately leaving the country. What are the retention plans?
Okay.
Thank you.
Those are two great questions. And can I also ask, given that there's probably a period where you'll be doing a lot of new training of health professionals, but we now have a heavy foreign presence in terms of healthcare provision, what's the plan on that? How long will it take to have the workforce in Liberia rebuilt, or how long do you anticipate, and how will you handle this kind of huge expat group that's hanging out there? Okay, let's take two more questions. Go ahead, second row.
I'm Stephen Kinoti, Dr. Kinoti from Few Corporation, VP for Clinical Solutions. I'm very excited about the proposed direction in strengthening infrastructure, and I would like to address myself to an area I think needs some attention, and that is decentralized care. I believe, like was indicated, that early diagnosis, early recognition, starting early treatment, and all the other processes that follow that leads to tracking and any disease, Ebola and others combined, starts from the community, starts from the decentralized services. It's very important to improve infrastructure to get the central facilities, but it's much more important to improve health system infrastructure in the periphery, in the communities. And today there are cheap, available technologies that can improve diagnostics, that can improve data capture, that can track patients very, very easily with very strong surveillance capabilities that can be applied in this for the future and for the ongoing interventions. I'm privileged to be part of a discussion with funding from Gates to customize a technology, FUNET, in Liberia to actually address this. Early diagnostics at the periphery, very much cheaper, limited infrastructure, but sustainable efforts. Thank you.
Great. Thank you very much. Okay, right in the back with the blue sweater, and then we'll turn back to our panel for a round. Go, Una. Just kidding. Thank you, Una.
Thank you very much. My name is Maurice Kofa. I'm the Executive Director of the Africa Environmental Watch and also co-chair for the Maryland, State of Maryland and Liberia sister relationship with respect to Bond County and Maryland County. I have been going to several of the conferences hearing about what happened with respect to Ebola. But one thing that I'm not hearing so loudly is the connections that the health sector has with some of the issues that we talk about with respect to the environment. Now, since this is a regional discussion with respect to Liberia, because of course the Mana River, composed of 4 countries, and of the 4 countries, 3 countries were impacted, except for Ivory Coast. But one thing we have not talked about that also impact our health system is the environmental condition in these 3 countries. Unfortunately, if they are not identical, but they are great similarities, how are we going to address the issue? Because if we do not address them, then of course we will not have a comprehensive health care system that we're talking about. I would like for the Minister of Public Works to address these issues, and he is the government representative here.
Okay, it's down to you. So let's stop there for a moment. We'll
Nancy,
go back
Nancy.
out. Okay, Nancy, because she's my boss. Go ahead. She got special
Thank you, Amanda.
dispensation.
I just wanted to mention that we spent a lot of time at CGD worrying over how good is USAID and how good is MCC.
We're great.
I think, and
The
how,
answer's already
how's
in.
the World Bank doing and all of that. And I think it's useful to say that the USAID's Office of Foreign Disaster Assistance is a standout.
Thank you.
And I think it's an unsung
Thank you.
part of USAID. I don't think you were here, Jeremy, when Minister Moore was worrying that Liberia will look bad in 5 years if there is the impression, as is the case with Haiti, that all this money went there and not enough happened. So could you say anything about it's, not, you work on urgent emergency issues. Is there some way that you can take leadership from your office on publishing the contracts that USAID makes and asking the contractors to make available the subcontracts? This is something that we've begged for in the case of the transfers to Haiti. And although I think it's all goodwill at USAID to do it, it's a task. It requires developing a system. It's as hard, maybe, as strengthening health systems in developing countries. If we can't do it in the US aid system, at least for the disaster assistance, where the U.S. is so fundamental and important, as the senator said, then, you know, I think it just makes it impossible for countries like Liberia to hold the U.S. system to account.
Great. Okay, so let's go to Jeremy first. Do you remember all of the questions?
I've been making
Okay,
notes,
excellent.
so I'll try to
Complete
cover
notes.
everything, but just shout at me if I miss something important. So I want to actually first speak to the point that Mead made about the competing models. You know, it's clearly important, and you're right to point out how this has worked in Uganda and DRC in the past. It's clearly important to have good surveillance and good rapid response. And you know, your ideal prototypical Ebola response would never touch 20,000 cases. You'd stop it within 10 or 20, if not. I mean, there've been some rounds recently where there's been as few as just the one index case, and it's been stopped there. And that's actually what happened in Senegal. So you don't, strictly speaking, need massive strength throughout the health system, as you pointed out, in order to stop this, nor is that sufficient to do it, as we've seen in some other places. But with that said, the point of the administration's global health security agenda is not just Ebola, it's also to look at Ebola as indicative of a broader set of challenges. And so, yeah, we could go in and at lesser cost just build an Ebola response capability in the region, and that's that's likely to be one of the outcomes. But that's not going to protect us the next time something else pops up, and it might not pop up just here. And what's frightening about this disease is it's very infectious, but it's not very contagious, relatively speaking. And so we need much greater capability to deal with the things that are more contagious as well as more infectious that could come around in the future. So that's to say it's not quite. I don't think it's quite the trade-off that you put forward, but I agree with the observation that it's not enough just to have strong health systems. You need to have strong health systems that also have some capabilities that are specific to this and can respond very quickly to this. On the longer range planning, I mean, I think your question to me and Nancy's question to me are pretty related around how do we ensure that the money that AID is going to put in the long run syncs up well with what we're doing now in the disaster response, and that we have public accountability so that we can be held to account, which is a fair point since we are the government. And this is a challenge. It's not just, I mean, it's a perennial challenge for AID. It's a perennial challenge for every donor out there. It's a perennial challenge for every NGO out there. And I think as an aid sector, we've been identifying that as a challenge for at least 20 years. We still haven't gotten it fully right, which I think reflects it's just a damn hard problem. In part, it's just really hard. We are within AID focusing really heavily on this transition question right now, and we've started discussions on looking at this huge machine that we've built for Ebola response. Not all of that needs to remain, not all of that should remain, but what are some of the pieces of that we would want to leave behind in some way, or capabilities that's going to develop that we would want to leave behind in some way? One important one is personnel. The health systems in these countries have been badly damaged. The personnel systems have been badly damaged. A lot of health workers have been lost. At the same time, we've gone around now and in all three countries trained up these huge armies of personnel who are working in the Ebola treatment units, who will have greatly enhanced skills in infection prevention and control, sanitation and hygiene. Those are skill sets that the health system is going to need in the future to be able to contend with a possible future flare-up of Ebola. So there are going to be capacities built that we need to make sure don't get lost then when those programs get pulled down. And one of the ways that we've done that, for example, within the emergency response, is actually building the infection prevention and control piece of the emergency response on existing AID programs that we're doing more general health system strengthening, so that there would be a natural layering in and syncing up of those different pieces, but also so that when my office's role pulls back, and thank you very much for those kind words, Nancy, when my office's role pulls back more, the system that we've set up will be more organically connected to the more sustained development programs that the AID mission in the country is going to take forward. I think that's a model that we need to use more often than we do, because too often we have different sets of partners and you don't get those connections. So we're trying much harder in this one to get those connections. Another challenge that we sometimes face, we didn't so much in Haiti, but in something like the Philippines response, there's a lot of goodwill about doing the longer range planning, but then there's not the funding for it. You get a lot of money for the disaster response, and then there's not a special infusion that comes through for the post-disaster, and it just kind of reverts to the normal flow of things. In this case, obviously, we got a large infusion from Congress through the emergency request, so we have the resources. There's a huge amount of will there to make sure those connections happen, and we're going to we're going to have to do it. And I would encourage this room to press us and hold us accountable, but also give us ideas on what we need to be doing, because, as I said, it's a hard thing to do to make sure those connections happen. If it were easy, we'd have figured it out and been doing it more effectively years ago. So we need the best collective thinking of this group, and I think the open letter is helpful, and the process that represents is helpful in keeping us oriented where we need to be oriented. On Nancy, on your question on accountability, there are efforts in the agency to be more transparent. We now have to register all the programs that we're doing into a system within AID. Also, any studies that we do, any impact evaluations that we do, have to be put into a system that will then be open to the public. This response is somewhat unique for OFTA in that we don't have any heartburn about doing that, because there aren't safety concerns or security concerns. Other places where we would not do that, something, in a place where there's a war going on or something, some of that can compromise our partners. We don't have that here, so we are it's an easier lift for us in this instance. One of the challenges, just to be frank, is bandwidth. We will this year about double our office's budget due to this response. We're working to get the staff caught up with that, but that hiring in the federal government, as I've found in the 15 months I've been there, does not move fast. So we are, we have a team that is, and I think this is typical of responses, and probably was the case in Haiti as well. You have a team that is so focused on do the job, do the job, do the job. It is hard to layer onto that another machine that takes that information, parses it, takes out what's procurement sensitive and things like that, and then pushes that out to the partners or to the public. I don't know. That's not a fantastic answer, to be honest, but I think it's something that we need to think more about and do more on. And there is a lot of goodwill, and there is an effort in the agency to do that. But I think it's going to be an iterative process. We'll do better this time than we did on Haiti. You'll bash us hopefully a little bit less, but still justifiably so. And then we'll do it better yet the next time.
Okay. Minister Moore.
So I'll try to remember the questions.
Yeah.
One is
Vertical programs.
yeah. There was a question about I don't think the draft is publicly available yet. I don't even but I'll talk to my colleagues when I get back, and then maybe they publish it on the Ministry of Health website, and maybe send it to Amanda too, and the Center for Global Development can publish that too. So I'll keep that in mind. In terms of you said something about having expats. This is what happened. I mean, Ebola. There was a lot of improvement happening in our health sector in Liberia before Ebola. Last year, the Ministry of Health wage bill grew by an extra 3,000 employees, simply because a lot of NGOs that were doing health work had gone down, and where they were before, the government took on the responsibility now. So as the country improves, it works out where the NGOs and the expat staff pulls out, and the locals take on more responsibility. Obviously now we're in a situation where we can't advocate that now. It's going to take a while for us to be able to get to the place where we can do that. But this year, the government also decided to improve the salaries for doctors, for healthcare workers, doctors, and engineers. It's not going to be so big that they're not tempted to leave the country, but it's going to be better than what it is now. And I think that's to address the retention question. People go into this kinds of public service because they want to help, they want to do good. Obviously, they have pressures too, economic pressures, and sometimes they respond to them. But I think generally, retention, especially for our nurses and physician assistants, and to address the question of decentralization. When I talked about a pyramid, about the largest number of people who will be trained will be community health workers. That's 25,000 of them. That's recognition that most of it will happen at the community level. It is about giving them ongoing training. It's about giving them support. There's a program, and a good friend of mine runs it, called, Raj, and it's called Last Mile Health. And what they do is they take a high school graduate living in a village and trains them and gives them these tests to be able to test for the top 11 killers. And they're able to provide, they're able to reach way more people than, say, a hospital, a stationary hospital that people have to be able to get to. And so, how such a model can be built into our health system is something we're thinking about. But the whole focus on 25,000 community health workers is an intent to decentralize our response. And I was saying something about the county health team. The county health team would not have to wait for Monrovia to be able to take actions, but the capacity to respond has to be at a county level. So we're going to do that. And then the environmental issues, general environmental issues or particular environmental issues, I don't know. Well, I would just speak to what I know.
You mean like roads and
When we do,
environmental?
okay,
Okay.
okay,
ahead.
absolutely.
Yeah. Okay.
I have to agree with you. The wash sector is oddly under the Ministry of Public Works. I don't know how that happened, but
Good news for wash.
but water and sanitation is under the Ministry of Public Works. And one of the I think one of the gotta be careful how you say this. One of the areas or challenges for our administration has been rural wash program, ensuring adequate water and sanitation outside Monrovia and Banga and Kakata, outside the cities. And as this is something we intend to correct because, we were very lucky in Liberia that this last rainy season, we did not have a cholera outbreak. Because if we had had a cholera outbreak while there was Ebola, I don't even want to think about what would have happened. But it still means that we could still run into problems with cholera and other issues that have to do with adequate water and sanitation and hygiene. We intend, so the wash sector is a big part of the Ebola response. Matter of fact, the preparation of the schools and community water, providing water in communities, the wash sector is now integrated as a cluster that is responding to that. And as Minister of Public Works, this year we intend to complete the the conditions for effectiveness for $10 million from it's an African pool fund to do more. I think it's about 250 borehole wells all across the country. But we're doing the best that we can to ensure that at least every village has clean water and and we're sending wash teams in there to talk to them, because the hope is that we can sort of mix wash in with the mobilization around Ebola so that you can accomplish the two things at the same time to be able to do it. But definitely it's something that's, the government should invest in, and something we intend to invest in. I hope I've answered your question, or at least said something.
Okay.
Thank you.
Okay. Hey.
We can just talk after this.
Yeah. Yeah.
Yeah.
Definitely an important issue. And I mean, one of the issues with WASH projects is that they have tended not to use the same kind of targeting that you would for disease response.
That's right.
And so it's great to hear that you're thinking of doing it together as a package. Chico, would you want to say anything about what the World Bank is financing in this area of enabling investments, either in not just direct health investments, but WASH and
Can I just say something quickly before he?
Okay, say something else.
Yes, one of the good things that the World Bank has done for us, and kudos to the World Bank for that, is that when we do big infrastructure projects, we have to pay resettlement action, because people's lives get affected, people in the right of way and stuff like that. So this year, the World Bank has approved $8 million, thereby freeing the government to continue such big projects, but without having to put such a burden on the so. Yeah.
Right.
Okay.
So it's
You have
always
two more minutes, and then I think we're going to wrap up.
yeah.
So go ahead.
No, I think maybe Mead would want to, but no, it's always better when the pliant to use the World Bank terminology. It says what we're doing rather than when I say what we're doing. So thank you for that. No, I just wanted to very quickly say something. There weren't any questions for me. I just wanted to say something quickly in response to this emphasis on the private sector, which I think is absolutely right? But to my mind, this is a very dualistic economy, like most African economies, West African economies are. There's two private sectors, at least. There's the private sector that operates in Monrovia, the big mines, the big firms. And then what's the private sector in terms of employment for, I don't know, 80, 90% of the population? That's self-employment in agriculture or elsewhere, and small little businesses. And my plea would be that when we talk about the recovery on the private sector, we think about both of those, and not just the biggest one. And also, one other thing, just to make things a little more complicated, the minister already referred to this, but of course, that big private sector is heavily reliant on things like oil and iron ore.
That's right.
And the world for those commodities going forward is a different world than the one we had in the last 2 years. And so Liberia would already be facing very substantial economic challenges now on the basis of those two commodities, even if it hadn't had Ebola. Of course, it has had Ebola. So we also must bear that in mind in the reconstruction and recognize that that country faces a very difficult environment going forward for commodity price reasons, unrelated to Ebola.
Okay, well, I think we're going to end now, and apologies to Meade for not coming back to you because it's 11:30 and we've been here 2 hours. So why don't, if you're in the audience, you had a question or comment, please feel free to approach the panelists. And thank you so much to each of you, particularly Minister Moore, for your inspiring leadership and voice. Thanks to you, Jeremy, Chico, Meade.